following this emotional part, we move on to the scientific part of our conference, and we will move to the first session, which has to do with cystic fibrosis complications. Now we'll call upon Ms. Diamandea from Cystic Fibrosis Centers, please. Ms. Diamandea. So you can stand there, and we'd like to call upon the rest of the speakers, Ms. Manika, Ms. Hadjiagoru, and Ms. Petroghilou, who is not arrived yet. I'll ask them to join us in the panel. Okay, so Mrs. Diamandea presentation. She's going to talk to us about the recent data from the triple combination effect in cystic fibrosis lung function in adults. Thank you very much. If we're ready. Thank you. Good morning from me as well. I'd like to warmly thank you for the invitation. My topic is recent data on the action of the triple combination in the lung disease in adults. So I'll be as brief as possible, but it will take more than 10 minutes. I'm going to share with you the data from recent research and together with the patients' registries, and I'll share with you some data pertaining to the patients from our own center. We all know that this triple combination restores, in fact, the functionality of the pathological protein at a high rate, more than 40%. In our patients. In Europe, right now, there's approval for patients with at least one mutation, Delta F508. In the States, it has been approved for even for those who don't have this mutation. And we have access to this treatment, and we'd like to thank the ministry for that, for giving us the opportunity to take good care of our patients. We know that at least 10% of functional protein is adequate in order to avoid the manifestation of cystic fibrosis symptoms. So we all are aware of the spectacular results of this drug in the respiratory function of such patients, and how it does away with exacerbations, severe exacerbations that need to be hospitalized. Now I'll talk about the action of the effect, rather, of the drug on the rate of the FEV. Now, in this study, which was published in 2022, there were two groups of patients. One with patients who participated in the approval studies of the group of the drug, and in the other team, the other group, we had patients from the American registry with the same mutations who were not on this combination. These are the demographics of patients. And what we see here, is there a pointer somewhere? Okay, so what we see at the upper blue line is that the drug, in fact, stabilizes the respiratory function. Whereas now for patients who do not take the treatment, there is a impairment of the functional of the respiratory function. The same goes in both groups, and this is in fact the first drug that shows stability of the respiratory function, at least in the depth of 2 years. So far, the high Vicaftor and the double combinations would reduce the impairment, but nowadays we see stability. Now, the second study, again, uses those patients who had participated in the approval studies and compares them with themselves 5 years before the administration of the drug and 5 years after. And now we have the data so far of the first 2 years. These data pertain to respiratory function, the exacerbations, the hospitalizations due to exacerbations, pathogens, culture, and potential implications on the liver. 60% of patients were on the treatment. And you see the 5 years before the treatment, there was an impairment of the respiratory function, a progressive impairment, and as a result, we see at the time where they started receiving the treatment, already in the first year there was an increase of 8.2 in the respiratory function, which was stabilized and reached 8.9% as compared to the pre-treatment period. We see here what was the case with the microbes. The vertical line shows when the drug was administered and how there was a lower prevalence of pathogens, both for Staphylococcus as well as for Aspergillus. It was reduced, but it wasn't eradicated fully. We see what happened with exacerbations and hospitalizations. Second year, we had a 79% reduction of exacerbations and 44% reduction of hospitalizations. And we see that there was an 85% reduction of lung transplantation risk. And 72% reduction of the death risk regarding complications such as upper airways, polyps, pararhinosinusitis, diabetes, stress and depression, and hypertension. There seem to be no changes in the 2 years from the onset of the drug. And with regard to the effect on liver, there was only an increase of bilirubin, and this changed. Now I'll show you data from our own patients of 2 years following the onset of treatment, and they come from the Greek registry. These are 86 patients who had a median age of 28 and FEV1 52% before onset, and we measured the respiratory function, then annual rates, and the IV administration days 1 year prior to the onset of treatment and 2 years after. So we see the characteristics of patients: 13 years on average of hospitalization 1 year before the onset, and here we see how much increased was the BMI in the first year, and it was stabilized later on. We see respiratory function plus 8.5% benefit in respiratory function in the first year and 10% in the second year. And in fact, the second year we had 0 hospitalizations as of the onset of the treatment. Therefore, this triple combination had a significant improvement to the respiratory function and nutrition of patients, and led to the significant reduction of exacerbations that would call for IV treatment. The efficacy of the drug remained stable in 2 years' time. Here are data from the European registry pertaining to 3 years, 2011, 2016, and 2021. You can see the age groups of patients, and you can see that Pseudomonas was reduced in all these age groups progressively throughout these years. There has been a reduction of chronic Pseudomonas infection in all age groups of cystic fibrosis patients. Here are data from the American registry. And you can see back in 2011, where we had the introduction of ivacaftor, and in 2019, the triple combination, how the frequency of the prevalence of the microbe is reduced. In the pandemic years, of course, it was reasonable for it to be reduced, but it was even more reduced after the onset of treatment. These are data from the Spanish Pulmonology Society, pertaining to 114 patients with 30 months follow-up. The vertical line signifies the onset of the treatment. You can see Pseudomonas, Staphylococcus, and Achromobacter are quite reduced after the onset of treatment, and Pseudomonas at some point is close to zero. So given data from the American registry, we have a reduction of the positive cultures percentage following the onset of treatment. We have these two studies researching what's going on with culture and microbes in cystic fibrosis following the onset of triple combination. This is a PROMISE study for patients above 6 years of age and begin with children under 6 years old. This is the first study where they studied sputum and culture, and we see that there is a reduced prevalence, but it is not eradicated fully. We have a stabilization in 6 months' time. And in this year's conference, they mentioned that the results remain stable for 1 year. However, despite the fact that Pseudomonas is not identified in culture, it is identified still in molecular techniques. On the left, we see patient 8, 17, 43, etc. In blue, you can see the positive Pseudomonas cultures. In yellow, you see negative Pseudomonas cultures. And in the second panel, we see that there are patients who were negative in culture. From blue, they turn to yellow. In molecular techniques, however, we were able to trace Pseudomonas in some of them. So it's not fully eradicated. It might be reduced. The burden is reduced, but the organism is there. We knew that already from older data with ivacaftor. In the first year, we have a lowering of the density of the Pseudomonas, and then it reappears. And now, following the after the respiratory function and the pathogens, they also studied structural characteristics, having a CT scan for patients in 1 year from the onset of the treatment. There was a 42% reduction of positive culture for Pseudomonas and Staphylococcus, and here we see the data pertaining to structural changes in the lung. In 53 patients, we had less bronchial wall thickening, in 7 less bronchiectasis, in 11 we had lower hyperinflation, etc. You can see the CT scans of patients before and after treatment, the improvement. This is, yes, another study which is really recent and was in Ireland and in the UK, and it pertains to imaging data as well. This study, aside from the improvement in lung clearance index, showed also an improvement of scores in the CT scan. However, we observed that what was improved was inflammatory lesions in the lung and not structural lesions. In fact, where there were structural characteristics such as bronchiectasis, there was no improvement. These are permanent lesions. Only the inflammation characteristics were improved. Now, I'll share with you what happened with our own patients, what happened with Pseudomonas. We're talking about these 86 patients I mentioned earlier, who have completed 2 years for treatment. We see, first and foremost, that following the onset of treatment, 35 out of these 86, 40.7% of them had no huffing, and there were cultures in pharyngeal smears. So Before they started the treatment, 87% had Pseudomonas. The first year, this percentage dropped to 78%, and the second year to 71%. And the status of these patients changed in 12.8% of patients. We are interested in seeing what happens with atypical mycobacteria. This is another study from Israel with the inclusion of the patients with at least one positive culture in the past 2 years and were on the drug for at least 1 year. In 9 out of these 15 patients, of whom 7 had abscessus, which was a very aggressive atypical mycobacteria, there was eradication, and at the same time there was improvement of their function. We're also interested in checking what happens with more aggravated patients with a less than 40% FEV1, because in general in the studies we had 40 to 90% FEV1 patients. So to see what happens with the patients with more aggravated function. So this is a study from 47 cystic fibrosis centers in France, and 9 of which were transplant centers, with 331 patients above 12 years of age with severe pulmonary disease, with less than 40% FEV1, who were in the transplant list or were to be included in one in the next quarter. And they were followed up for 1 year. Out of these 331 patients, 45, or rather 65, correct the speaker, were lung transplant candidates. 17 were already on transplant list, 48 were considered for lung transplantation. So what came out at the end of this treatment after 1 year? Only 2 patients underwent lung transplantation, 2 remained on the transplant list, and out of the 65, 61 were no longer meeting transplantation criteria. As we see in this diagram, in the black color, you can see that during the months there was a reduction of the percentage of patients who were candidates to transplant. Their FEV1 was improved, and the same benefit was seen in patients with lower FEV1 initially. You see progressively there was a reduction of oxygen use at home and reduction of the BiPAP. I'll share with you our own data for our own patients who were lung transplant candidates. We followed them up, or rather we included patients who had severely aggravated FEV1 and who had completed at least 2 years of administration. We checked what happened in the first month and in 2 years' time. 13 such patients, out of whom 4 were in the list and 9 were to be included in the list. These are the genotypes. We see how there was improvement in month 1 of the BMI. The FEV1 was improved in the first month, and then it was stabilized, and there were less exacerbations. There were no hospitalizations for these patients because these are severe exacerbations with a need for IV treatment. No patient was on oxygen at home, and no one was included in the transplant list after the onset of the drug in these 2 last years. Again, data for the respiratory function from the registry we see for the several age groups and how this was reduced in the 20 years. So 56% was the average for respiratory function, and now it reaches 80%. Less exacerbations, severe exacerbations with the need of IV antibiotics in 2018. This is from the American registry. 43% of adults would need IV treatment, and this dropped to 15% in 2022, respectively for children 23% turned to 10%. Again, other data from the American registry, you see how the exacerbations are lowered. What happens with inhaled antibiotics after the onset of the triple combination? We see here some clinical signs that are really important. The inhaled antibiotics are prescribed in patients with a triple combination for this respiratory infection that still remains, and the patients are recommended to continue this treatment. Clinicians need to decide about the cost-benefit in case they decide to stop this. And despite the fact that these are highly effective drugs, they do not normalize lung physiology, they don't stop inflammation, and they don't resolve chronic lung damage such as bronchiectasis. In fact, so far there have been no studies justifying the discontinuation of inhaled antibiotics, and we need to have more research. Now we move on to lung transplants. There was a reduction in lung transplants. These are our data. In the blue bar as of 2014 and onwards, we have the referrals, and in yellow in red we have transplantation. So there is no list of us in the list. There's no patient of us in a list. Survival was increased. The median survival 36 years in 2002, 56 years in 2022. The median means that at least half of the patients will reach that age. And this can also be seen here in the American registry. At the same time, a drop in mortality rates. The American registry on the left and the European registry on the right. 58% of patients in the US and 54% of patients in Europe are adults. The green bar corresponds to adults. The yellow bar corresponds to children. You can see the increasing number of adults. And this is a projection model that was presented in last year's American conference that shows that by 2040, the number of adult patients with cystic fibrosis will be 70%, whereas the number of pediatric patients will remain approximately stable. Conclusion. From the data so far, we see that the triple combination has a significant benefit for the FEV1 of patients of at least 12 years of age. The benefit continues to remain stable in 2 years' time. Patients with a severe pulmonary disease have similar benefits regarding their respiratory functions as patients who have been included in the approval studies, and a significant percentage of those who had been in a transplant list have been taken off the list. Despite the improvement of the FEV1, the inflammation and infection remain. And the triple combination is a disease-modifying treatment. Thank you.
Mrs. Diamanta, all this is very striking, but please sit here. Keep your questions for the end. I myself have many questions. Remote viewers can also send their questions. The next speaker is Mrs. Perlepe Garifallia Irini from the new clinic at Larissa, together with Mrs. Carecci. They are doing very good work. She's going to talk about aspergillus. Aspergillus is a matter of concern for many patients. She's going to talk about it. Good day, Mrs. Perlepe. Thank you for being with us. We are not receiving sound. Yes, now we can hear you. I apologize sincerely for being unable to attend. I was on call and I could not change that. Thank you very much for the opportunity of including me. It's very interesting conference. Mrs. Carecci and myself Of course, we only assist, we have an assisting role only, but we are eager to help people in our remit so that they can have someone to call when they need help. Okay, I will start my presentation and I will try to summarize as much as I can. Are you looking at my slides? Yes, we do. I will try to the best of my abilities to summarize the information from the literature in view of respiratory disease caused by Aspergillus. I will start with some research information about this fungus. This fungus has a very distinctive morphology that allows it to attack the host. It has a basic part, texture, and another part, a conidiophore, which contains the conidia that through breathing reach the respiratory system of cystic fibrosis patients. And they are trapped in this mucus, which is a feature of the disease. This process is called colonization. Under the effect of various parameters, I'm going to talk about them, the immunological system is being activated with free radicals. The disease moves to deeper epithelial layers, and we have these textures. This is the typical cellular and histological image. Aspergillus should be a priority for patients with cystic fibrosis. There is the physiopathology behind this. The malfunctioning of CFTR induces an inflammatory response which favors hyperinflammatory responses in Aspergillus and cause this aspergillosis. We know from in vitro studies that mice with a poor CFTR function have a poor clearance of this fungus in the lungs, and the typical mucus is a very good environment for Aspergillus colonization. In addition to the damage caused by the CFTR, the high incidence of bacterial infection is another risk factor. That's why the chronic use of antibiotics for fungal infections increases colonization from fungi. You see the use of inhalers creates colonization from bacteria. You see the percentages, Candida and Aspergillus. In this big literature review of 6,000 patients, you see that the constant isolation of Aspergillus is found in 9.6%, and here risk factors associated with isolation are the inhaled antibiotics, macrolides, and corticosteroids through the nose. What does Aspergillus causes? One can say that the less infectious situations are the mere colonization incidents, a sensitization. I will explain the difference. And then disease which calls for treatment, allergic aspergillosis, aspergilloma, bronchitis associated with Aspergillus, or invasive infiltration disease, which is rarer. For colonization, information varies a lot. Some studies speak about 5 to 78%, 3.9 to 42% elsewhere. It is the strain of the Aspergillus. Aspergillus fumigatus is the most frequently found strain, and we have to be vigilant because it is something that we have to check for. There are various laboratory tests that can help us classify patients in one of the categories I mentioned. A patient who is merely colonized will have a mere isolation identification in a sample from the upper respiratory. A sensitized patient might have increased levels of total IgE or specific IgE antibodies for Aspergillus. In aspergillosis, we also have a very high IgE combined with positive antibodies for IgE and IgC for Aspergillus, and also another product of the fungus that can be found in sputum and in FAM and in bronchitis or infiltration disease. We have increased IgE, specific IgE, and the last one. The big question is whether this mere colonization tell us something, if it has any clinical significance. It seems in the international literature to have conflictual findings. There are merely colonized patients with lower pulmonary function, increased risk for pseudomonas, increased risk for exacerbations, but there are other studies which have not associated Aspergillus colonization with malfunctioning. It is very hard for the clinical physician to associate knowledge about the forms of the disease with the clinical findings and findings from imaging, MRIs mostly. But clinicians should always be suspicious. In addition to CT scan, patients should explain their clinical systems, coughing, sputum, dyspnea, or spitting blood. These are symptoms that are increased in patients with bronchitis or bronchial aspergillosis, perhaps combined with respiratory impairment. As to findings from CT scans for aspergilloma, imaging techniques are very significant. The typical image is diagnostic, a ball, in fact, a fungal ball within a pre-existing cavity for infiltration disease and bronchitis. Usually we have nodules, there is bronchiectasis, alveolar shading, whereas for aspergillosis we have central bronchiectasias with a hyperdense material. There are these typical images. You see here to the left-hand side the typical ball or orb with air above and around, above in patients with aspergilloma. Lower left-hand side, nodules with thick walls in the bronchi in Aspergillus-associated bronchitis, and to the right-hand side, you see the very typical image of bronchiectasis with this content, which is hyperdense. In bronchial aspergilloma, you need to do all the routine tests and treatment. There are criteria. We need to have two criteria: positive findings, increased IgE for aspergillosis with very high levels of IgE, as I mentioned earlier, and combination with two of the following elements: IgG antigens for Aspergillus, imaging, typical imaging, or increase of eosinophils over 500. For bronchitis, we have elements from patients without cystic fibrosis and guidelines on the documentation of the disease. There should be cellular material or bioptic material that is typical. We need to have a detection of the fungus in association with textures and laboratory findings. The disease may be probable or certain depending on information from the host, clinical information, or lab criteria. Especially for cystic fibrosis and bronchitis and positive disease, we need to consider this when we have two cultures with isolation of Aspergillus, when we have new symptoms and impairment of respiratory function, when we have divergences. This is very important with comorbidities for which patients take treatment but don't respond to treatment. When the image is compatible and when there is response to fungal treatment, this is a powerful sign. Other minor criteria include lab tests, lab criteria that we might have. And we move to another important factor extensively found in the literature. There seems to be an increased and frequent coexistence with Pseudomonas. This is a vast slide, I'm sorry, but you see that there are very mechanisms by which the two microbes compete with each other, and through this competition they coexist in a host. And we care about that because there are observation studies that note exacerbation when we have coexistence of Aspergillus and Pseudomonas. This is a co-colonization, reduced FEV1, more frequent hospitalization, more frequent exacerbations, increased use of antimicrobial treatment. From the UK, a study references with lower body mass. We have to keep this in mind. Now, treatment choices. The big question is to distinguish, for the doctor to distinguish based on the available information, if it is colonization or if we have active infection. However, there are studies that consider whether merely colonized patients should retrieve treatment. We have conflictual evidence here. There are treatments like this randomized study. It showed no effect for primary or secondary signs, exacerbations, or IV antibiotics, and pulmonary impairment. Another study in Ireland showed that treatment can reduce the mediators of inflammation associated with the disease and perhaps improve results in the CT scan. But it seems what we should keep in mind is that we have conflictual evidence. For pulmonary aspergillosis, there are clear instructions, corticosteroids, clearly, a lot of adjunctive treatment, supplementary treatment. Usually the dose for the acute phase and exacerbation is 1.5 milligram per kilogram, and then a gradual reduction depending on IgE levels, which show response to treatment. As to antifungal, their role is questioned clearly. Some studies show that by reducing the fungal load, there are positive effects, but antibiotics, the use of antibiotics is inconclusive. For bronchitis and infiltrating disease, the first treatment line and choice is corticonazole or liposomal amphotericin beta in highly refractive areas. You see the dosages and a systemic treatment. For patients who are colonized and get a lung transplant, preventive voriconazole is recommended. It has been associated with reduction of pulmonary disease. We know that azoles are well tolerated, but there are effects associated with hepatotoxicity or changes in vision or neurological disorders or increased sensitivity. And something else, voriconazole and traconazole are activators of C3A, and we have serious problems in co-administration with CF modulators. We have to be careful about the dosage, and other factors are also involved. We have various choices where feasible. Treatment should be administered in patients with documented disease, as many problems may arise. What seems to be gaining ground in international literature is that azole treatments have a place. We know that amphotericin beta, much more than azoles, they have pharmacokinetic properties that allow them to remain for longer intervals and therapeutical windows in patients, and we can have a good and effective treatment. There is indication as a prophylaxis in lung transplant. From these patients, we have most data. We can have the measurement of the various levels and decide whether they're healing. There doesn't seem to be a lot of penetration in systemic circulation, and this is the interesting point because they will have lower risks with co-treatment, and many studies deal with therapy for hypertasic infection, where there is a question mark. And I will conclude with this message. Although Aspergillus has a great span of action, like other microbes which are traced in cystic fibrosis patients, we know that modifier treatments have reduced colonization in these patients, and this is encouraging. Thank you very much.
So, within this framework, and due to this difference between the official indication of the drug in the States and Europe, this year we had the publication of a very interesting study that was conducted in France, a palliative program for people without delta F508 who were above 12 years old and who were with an advanced disease, FEVF under 40%, or probably in the list for transplant. So this combination was administered for 4 to 6 weeks, and it was evaluated by a committee consisting of at least 3 experts in cystic fibrosis patients, 84 people, 16 children, 68 adults with advanced disease, of whom 23 had at least one mutation for which they would have been given the triple combination if they were in the States. FEV1 32%, low BMI 19.3 kilograms, 27 people suffering from diabetes, and quite a few of them had oxygen at home or non-invasive ventilation at home, which goes to show the severity of the disease. So in 4 to 6 weeks' time, 45 people out of these 89, that is 54%, considered that they had a favorable response. Of them, 23 people had at least one mutation approved in the US by the FDA, and 39 people did not respond. So you can see the responders vis-a-vis the sweat test here on the right, and on the left, the FEV1 response rates. Regarding those who responded, 45 people responded after 4 to 6 weeks of treatment. There was a reduction in chlorium in sweat by 30 millimole, improvement in respiratory function and weight, improvement of symptoms, and people who were on the list were off the list. Out of these 45 people, 22 patients without the approved by the FDA mutations, there was again seen a reduction in the chlorium of sweat, an improvement overall. What was observed was that those patients with the N1303K mutation seemed to respond, 8 such patients. This is the list, the table of patients who did not carry these mutations that were approved by the FDA, and the first 8 had this N1303K mutation. The characteristics of those who were non-responders, 39 non-responders without any difference in sweat chlorium or respiratory function or weight. Some of them had improved symptoms. However, this was not considered adequate reason for a response evaluation. So this study concludes that a significant part of people with cystic fibrosis and advanced disease might suffer from rare mutations that have not had approval in Europe, and they might be able to show improvement. Those with mutations that have been approved by the FDA, plus those with the N1303K mutation. Within this framework, there is also a publication in a small series of 8 patients with this particular mutation, 2 homozygotes and 6 heterozygotes, who were given this triple combination for 8 weeks, and they showed improvement in respiratory function and weight. And a last study on that specific subject showed that we can get nasal epithelium cells. This is easy to get from cystic fibrosis patients, and then cultivate them with the CFTR modulators. And we can see the response at the cellular level of the CFTR function. This was done for 39 patients, and as you can see, each bar shows at the molecular level the response of the CFTR. So the higher the bar, the better the response of the CFTR to modulators. Now, those in dark blue show those with mutations that have been approved by the FDA. Therefore, we see that there is a great heterogeneity vis-a-vis the response, but those mutations that have been approved by the FDA show the greater response. What is really important here is that we can predict from the cellular response the improvement of the respiratory function and the sweat test when such patients are given the drug. And I will conclude showing you this case, the data of this patient. I have been approved to share. So one of our patients, 34 years old, with the N1303K mutation with this advanced disease in the imaging exams, and we started him on triple combination in June. You can see the before and after data. Increased weight by 4 kilos, improved FEV1, 106%, and there are no exacerbations. This was the main problem with regard to this patient. He had 4 exacerbations in the past year, whereas in the last 5 months he's doing really well. Now there is yet another patient with the same mutation who has just started getting the triple combination, seems to respond, and we have administered the drug in another 2 patients with very rare mutations, and we don't know whether this has a positive response or not. Although it's quite early, it seems that one is a non-responder and the other one shows an improvement of symptoms and a reduction of insulin needed. Thank you.
Thank you, Mrs. Manika. Many questions to you afterwards. Now, Mrs. Fotoulaki Maria, she is connected virtually from the University of Thessaloniki. She's going to talk about the impact of innovative treatments on nutrition and on the digestive system. Do we have Mrs. Fotoulaki online? She hasn't connected yet. Let's go on to the next speaker, and as soon as she is connected, also virtually, Mrs. Eleni Papadaki from Hospital Papanikolaou is going to talk about sleep disorders in adult patients with cystic fibrosis. Is our connection with Mrs. Papadaki on?
Ωραία, είμαστε έτοιμοι λοιπόν να συνδεθούμε με την κυρία Παπαδάκη από τη Θεσσαλονίκη.
We are ready to connect to Mrs. Papadaki from Thessaloniki. Good day. Thank you very much for this honorary invitation. Can you hear me? We can hear you, but we do not see you. Hopefully we will see you in a moment.
Αυτά είναι με τα διαδικτυακά.
Well, that's the problem with online connections, but technology make it possible nevertheless. Welcome. Hello, thank you very much for the invitation. Congratulations for the organization. I will talk about sleep disorders in patients with cystic fibrosis, adults, and I will rely on a study that we conducted in Papanikolaou Hospital with cystic fibrosis patients. What we know is that although cystic fibration patients have similar sleep architecture with normal people, non-patients, however, cystic fibrosis patients complain about their sleep. From a study between patients and non-patients, SF patients had sleepiness during the day more, and their quality sleep affected negatively their quality of life, according to the relevant scores. And the most frequent disorder is hysticonemia. We were based on questionnaires mainly, and there is an association of sleep disorders with respiratory function and other clinical parameters. All patients were submitted to spirometric measurement. There were questionnaires, the Kerem questionnaire about coughing, and the 3 questionnaires for sleep quality, Pittsburgh, ESS, and AIS. A few words about questionnaires. The Kerem questionnaire is the only questionnaire for cough studied in cystic fibrosis patients. It quantifies coughing during the day and during the night and has a score from 1 to 4. 4 corresponds to more intensive coughing. Sleep evaluation questionnaires, in general use, the most frequent ones. The Pittsburgh is the most widely used questionnaire to appraise sleep quality. It is comprised of 19 questions about 7 categories of problems, and there is a score over 5 indicates poor quality for sleep. Epworth scale, daily somnolence, positivity limit 11. Then we have the Athens with 6 as a border. Now the effects of this the findings of the study: 18 patients participated. The mean age was 30.17 years. BMI 26.36, F1% 58.93. We hope you have time to read through these. It was found that the mean value in the Epworth score was 6.61. This is increased somnolence during the day at the upper levels. 2 out of 2 scores had over 11. The mean score in Pittsburgh was 0.6, which is 5 is the highest normal limit. 3 had a pathological over 5, and 22% had a score exceeding 5, so pathological. And the AIS questionnaire, the Athens questionnaire, the mean was 4.39. 8 out of 33.3% had a score, a pathological score, and of these 6 patients, 4 had mild insomnia, 1 moderate insomnia, and 1 serious insomnia. 7 out of 18 patients, 38.8%, had pathological scores in at least 1 questionnaire. 1 patient had pathological scores in all 3 questionnaires, and 2 had at the same time pathological findings in 2 questionnaires. As regards the association of Pittsburgh questionnaire with clinical parameters, it was found a statistically negative association between the Pittsburgh questionnaire and oxygen saturation. Patients with lower saturation rates had worse sleep quality. Now, as to the association of the coughing questionnaire and the other questionnaires, it was found that the intensity and frequency of coughing during the night is associated with the Pittsburgh questionnaires and the Athens insomnia scale in a statistically significant way. So patients with worse cough have worse sleep quality. As regards chronic infection from Pseudomonas, there is a statistically significant difference between patients with or without chronic infection as to intensity and frequency of coughing during the night. The chronic patients have higher scores in this respect, i.e. more coughing. In the conclusions of this study, 8 out of 37 patients, 38.8%, a very great amount, had pathological scores in at least 1 questionnaire for sleep. The mean value in Pittsburgh was 5, which indicates sleep disorders. 16.6% of patients had pathological scores in Pittsburgh, 22% in the upper normal range. The mean average in EPCOF was 16.1, which means increased somnolence during the day in the upper normal range. 2 out of 18 patients had pathological scores in Epworth questionnaire. 6 out of 18 patients, 33.3%, manifested insomnia, mild, moderate, or severe. Patients with low saturation in a resting pace in rest have worse sleep quality, according to Pittsburgh. The severity is associated with insomnia. You can read. You can read the findings. The interpreters cannot make it in time. Generally, sleep disorders in cystic fibrosis are frequently underdiagnosed comorbidity. These 3 questionnaires are useful tools to evaluate sleep quality in patients with cystic fibrosis, just as in the general population. They can easily be included in patient appraisal in the annual control as a screening method. Patients with pathological scores should be referred for registration. Thank you for your attention.
Ευχαριστούμε, κυρία Παπαδάκη.
Thank you, Ms. Papadaki. Will you be staying with us for the questions in the end? Yes. Okay. I don't know, Ms. Fokietulaki, is she ready? Otherwise, we can move on to Ms. Petrohilou, who is here. Now, Ms. Petrohilou from the Children's Hospital, she's going to talk to us about the more recent antibiotic treatments for cystic fibrosis. Good afternoon. Thank you very much for the invitation. I'd like to congratulate you for having organized this. It is very nice to see you again. Now, I'll be very brief. These are the recent antimicrobial advances in cystic fibrosis. So we'll talk about the available ones because there are some new data. Then we are going to move on to some new antibiotics that will be coming, but also other methods of handling the infections, because as you know, resistance to antibiotics is a big problem, not only for cystic fibrosis, but for all diseases globally. So since we are running out of antibiotics and we have resilient microbes, then we try to find new ways to deal with infections. We'll be talking about inhaled antibiotics mainly because these are treatments that were able to greatly improve the quality of life of patients. These are inhaled, they can be administered at home, they work against chronic infections, and they maintain a very low load burden that allows us to reduce the symptoms, and they are also useful in the eradication of Pseudomonas, the one that is of interest in cystic fibrosis. So this allowed us to reduce hospitalizations as compared to the past, since we were using the combination of inhaled antibiotics with per-course antibiotics or on their own. Starting from a very old drug, colimicin, which is available for inhalation. We used to use the powder, which is for IV, and the nebulizer use, and currently they are starting in order to have it approved by the FDA. There is a much more specific powder for nebulizers, but there's also the dry powder device with dry powder capsules. It's something like the inhalants of the Ireland type, etc., in order to allow for a very quick inhalation twice every day, which lasts less than 2 minutes. Many times with a nebulizer, the children need to use the nebulizer up to a quarter of an hour, which leads to difficulties in quality of life. Tombramycin, a second substance used. This is aminoglycoside, and we know that it's really active for Pseudomonas. It does have an action on other microbes, such as Staphylococcus, but we mainly use it for Pseudomonas. And we used in the past the IV preparation through the nebulizer. However, then we had a special solution made for nebulizers, which is both for the eradication as well as for the chronic treatment of Pseudomonas. And we can also find it in dry powder devices. In the past few years, allowing us to reduce the treatment time. 4 capsules inhaled in the morning and the same at night. So, although there is no resistance to tobramycin, inhaled tobramycin, since there are strains of Pseudomonas that are resistant to the drug, we study in order to add yet another substance which is called EDTA calcium, which is going to improve its efficacy. And we consider that it's going to be really useful for chronic infections because it does break the biomembranes, the biofilm. This resembles a membrane made up by microbes. So it's like a plexus, a grid, whereby microbes become more resistant to antibiotics. They join forces and therefore they are much more strong, not allowing antibiotics to enter the mucus. Therefore they become much more resistant. And this is considered that it's going to be breaking the biofilms and biomembranes, and thus the drug will reach the microbes easier, in an easy way. Astronam, also in circulation, again for Pseudomonas, for the time being only through a nebulizer, the appropriate dosing 3 times a day. There are certain studies speaking about 2 twice a day. But 3 is what is recommended. This is also helpful for children showing tobramycin resistance or not helped by colistin. And there are also data on chronic infection with Pseudomonas, as well as for eradication. Amikacin. The IV preparation has been used for years for the treatment of atypical mycobacteria, but it can also be administered in case of Pseudomonas. Atypical mycobacteria are very small microbes resembling the tuberculosis microbe, but they're a bit different vis-a-vis cystic fibrosis. These are atypical, and they are particularly well, it takes a lot of combination treatment, so we use amikacin. Already in the States, we have the preparation of which is particular to nebulizers, and in fact, we're going to have it here soon. We had clinical trials in Greece as well on amikacin, and it seems to be quite effective. Moving on to recent advances. I'm going to talk to you about gallium, a heavy metal. In clinical phase 2 trials, that is, it has been tested on humans. It is available in IV form and inhaled form. Already, IV has been approved in the US for multi-resistant infections, and now we have studies, particularly for patients with cystic fibrosis. And they are trying to have it in the inhaled form. Gallium is a heavy metal that resembles iron. And since the Pseudomonas uses iron in order for it to grow and proliferate, gallium replaces iron. The Pseudomonas believes that this is iron, and it absorbs it in order to use it, but it's not iron, and this leads to its destruction. So it's really useful for resisting Pseudomonas infections, and can be used in combination with typical antibiotics and act synergistically. Another molecule used is inhaled nitrogen oxide. These two in clinical phase 2 trials. Nitrogen oxide inhaled, has a strong action, antimicrobial and anti-inflammatory action, and it is currently being studied in clinical phase 2 studies for atypical mycobacteria. It is considered to be breaking biomembranes, biofilms, and it will be in the inhaled form. The studies are quite good on that. And the last one is the phages. Many people are interested in that, from what I hear. The phages are not something new. These are viruses existing in the environment. In the early 20th century, before, in fact, we discovered antibiotics, there was the use of phages in clinical trials for patients suffering from several diseases. However, as soon as we started having the antibiotics, well, they were easier to use and they were of a broader spectrum. Therefore, we abandoned the phages for years. But nowadays, with the problems with resistance to antibiotics, they have been brought back on the scene, and they are in clinical trials, phase 1 and 2, for resistant Pseudomonas infections. But there are also studies pertaining to Staphylococcus. The resistant Staphylococcus is a big problem for cystic fibrosis. Phages dissolve the biomembranes as well, and they are going to be inhaled. The phages do pose many different advantages. First and foremost, they are not antibiotics. It's something we find in nature. It's reproducible. It's at a low cost. It's safe. There are not many side effects. And we need a small quantity. One phage is enough to kill a microbe, and they proliferate in the body because they are viruses, they are inhaled, they proliferate on their own, and they combat and they fight microbes. They have a very narrow therapeutic spectrum in contrast to antibiotics. They act on specific microbes or even a subspecies of the specific bacterium. And this is both good and bad because there are no disorders and imbalances in our normal flora, but we need to know exactly which microbe we need to treat if we are to administer the proper phage. And we need to know this in advance, which is a problem for cystic fibrosis since we have multimicrobial infections there. And there's not just one microbe that we want to fight. Moreover, there are some theoretical indications. Since phages are viruses, they too interact with our immune system. Therefore, they might increase inflammation. There are some indications that if there is already an inflammation, which is really intense in cystic fibrosis, this might lead to the mutation of the phages, rendering them inactive, or this might lead to a further increase of inflammation because it's an infection. We inhale voluntarily a virus. Despite that, this doesn't seem to pose a significant problem. It's quite rare. So what we are currently trying to do is to prepare special phages mixtures in order for them to have a broader spectrum and be more efficient for our patients. For the time being, we have two mixtures going on in these studies. So the APPA02 mixture. In the lab, there was a successful result of 80%, and there's also BX004A, quite efficient, and it seems that they will move on and we'll find something for the resisting Staphylococcus. Thank you.
Πολύ ωραία, τελευταία σας διαφορά.
I really liked your last slide. Thank you, Mrs. Petrohilou. Mrs. Fotoulaki is okay with her connection, I think. Oh, great. Good morning, Mrs. Fotoulaki. Hello, how are you? I'm sorry for all these trouble. I'm very sorry I was unable to be with you today. There was an emergency that forced me to be away in Thessaloniki. I have faced some difficulties here. I'm trying to share my slides. Hope I will make it. Can you see my slides? We can see them all together, however. Yes.
Εντάξει, είμαι πολύ περήφανη.
I'm very proud. I mastered technology. I connected through a hotspot, finally. Let me thank the organizing committee. Mrs. Fotulaki, let me interrupt you. We are looking at all your slides. We should be looking only at the first one. Perhaps you should press F5. Wow, and I was so proud. Yes, we are seeing them, but we would like to see the first one. Okay, I pressed F5, but nothing happened. Okay, end of projection.
Να τις βάλω, πριν κάνω share, να τις βάλω όλες μαζί.
Before I share, well, it is the low right-hand button. Yes, when I press on this one. Stop the share screen.
Πίσω το share screen.
Ανοίξτε το να φαίνεται η πρώτη σε...
Open the first slide so that you can look at it. Yes. And do share screen now. I'm not looking. Where is the share screen now? I can't see it. Oh, it's not on the screen, the share screen.
Ναι. Okay. Την είχα κατεβάσει στο... Εδώ είναι. Όχι, λάθος. Επιφάνεια εργασίας πρέπει να πάω.
Ναι, αυτά έχουν οι ζωντανές συνδέσεις. Θα κάνουμε λίγη υπομονή.
This is what happens with live connections. Yes. Some technical instructions are conveyed to the speaker. We will resume interpretation as soon as she starts her presentation.
Ναι, αλλά έφυγα εντελώς εγώ από το Zoom τώρα. Περιμένετε. Θα ξαναμπω. Είχα κι άλλο Zoom.
Ωραία. Για να μην, επειδή έχουμε καθυστερήσει
Θέλετε
λίγο...
να προχωρήσετε?
We are lagging behind time. Could you do it without your power? Could you do your presentation without your PowerPoint? I have it in front of me. I can do it. Okay, you look at your slides and describe it to us, and we are just going to be listening to you without looking at the slides. This paper is about the effects of innovative treatments on nutrition and the digestive system. We have many signs in cystic fibrosis from the digestive, and they are related either to the digestive system itself, the pancreas, the liver, the small intestine, or they appear as a complication from other systems, as for instance, severe respiratory malfunctioning, which through mechanisms that we should not develop here, can lead to gastroesophageal regression or subnutrition. Of course, you cannot look at the slide, but the symptoms are not specific to cystic fibrosis, digestive. It can be a range of systems, especially nutrition disorders. The main organs involved in these disorders are the pancreas, the liver, and the alimentary canal. Let us talk about pancreatic function in cystic fibrosis and its role in nutrition. We have talked about this so many times. We know that a large percentage of children, over 85%, has pancreatic failure. And this is reflected in digestion disorders in the uptake of nutrients. What happens with treatments, with the new treatments? It seems that pancreatic function can be restored to a very great percentage, up to 41%. According to a study, the mean children's age is 6 years old. Up to 41% of children with pancreatic failure had their pancreatic function restored, and the pancreatic secretions could lead to digestion and uptake of nutrients for an average time of 5 years. Let us keep this in mind because it's very important for the use of these agents from early in childhood. A further finding from the pancreas, we know very well that more than 15% of children with pancreatic sufficiency, some generation of enzymes, such that they are able to digest and uptake foods without an image of pancreatic failure and subnutrition. Of those, 20% suffer of relapse pancreatitis. Treatment in these children in acute pancreatitis is no different than the treatment of children without cystic fibrosis. And what studies have showed after the administration of the new modulators, it was found that their administration reduces the risk of relapsing acute pancreatitis. The result of relapsing acute pancreatitis was, in the end, pancreatic failure. So the administration of these drugs achieves. Well, these children preserve a sufficient pancreatic function. Another important role of the new drugs is their impact on the microbiota in the intestine. The microbiota is very significant, and it's very variable because of the antibiotics, because of disorders in the evacuation, the gastric evacuation, the modification of pH in the intestines because of the hydrogen pump inhibition. Many children have gastroesophageal regression. All these changes the microbiota, and it has been found that changes in the microbiota lead to increase of intestinal inflammation, and the increase in intestinal inflammation is associated with the gaining of weight. Furthermore, changes in the microbiota also lead to a change in the intestine-liver axis. the permeability is increased and inflammatory cytokines go to the liver through the blood circulation, and then we have an attack on the liver. The administration of these agents reduces inflammation, improving the microbiota. And as it seems from the reduce of calciprotectin, which is an indicator of intestinal inflammation. As to the liver, I was asked to speak more about the liver. Hopefully, in the little time I have at my disposal, I will be able to explain the role of these agents in the hepatic function. CFTR, as we know, is cholangiocytals in the fatty cells. Cystic fibrosis is characterized by hepatic attack. Hepatic attack is a general term, and it is different by hepatic disease due to cystic fibration, which is the hepatic attack is a general term, as I said. So the manifestations from the liver in cystic fibrosis patients is about the parenchyma or the the biliary system. And we have various symptoms and signs there. And also, we have to keep in mind that there are other factors like infections, pharmacological treatment, cardiac function also affect hepatic function. Equally important, in 70% of people with cystic fibrosis, we have hepatic steatosis, to a very great extent, 70%. There are many factors that lead to hepatic steatosis that can use to hepatopathy, disorders to the enzymes, fibrosis that can lead to cirrhosis. Subnutrition in the past was the main finding. Now it seems to be obesity, together with other factors. The microbiota disorder. Espagan and Aspagan have defined clearly the conditions, the hepatopathy of cystic fibrosis due to CFTR. It's a multinodal cirrhosis without hypertension. There are various terms that are used. And some children do not have any hepatic attack. I used to have a very nice scheme that would show you how a disorder in CFTR protein in cholangiotic cells can lead to inflammation in the liver, or the microbiota disorder, dysbiosis in the intestine leads ultimately to the secretion of hepatotoxic cholic acids that are either absorbed by the blood circulation and damage the intestine, or precious cholic acids are lost, eliminated through the feces, or some factors are activated that increase fibrosis in the hepatic parenchyma, and all these factors together lead to these hepatic disorders that perhaps are not frequent. It's only 5 to 10% of the children that manifest hepatic disease due to cystic fibrosis. And until adolescence is the time where this hepatic attack is manifested. And later on, the percentage is stable. And there are no new manifestations in adult patients of hepatic disease. Of course, this is something relative. It is investigated, and it seems that even adults, young adults, might have it. It is a serious condition because it is the second cause for transplant, used to be until now, following lung transplant. Up to now, we gave Orsofang with many properties. We are not very enthusiastic today, as we used to be in the past, about this, because we have increased transaminases or increased gamma GT or a family in the ultrasound in the liver. According to our old definition, today, in the era of new drugs, we see that these new drugs can be associated with transient increases of hepatic enzymes in a 5 or 10% of patients. But we don't see an exacerbation of the hepatic function despite their administration, if not in patients with pre-existing serious cirrhosis. So, we recommend these drugs in all patients unless they suffer from severe hepatic disease with hypertension. In some of these patients, there have been a colic has been described and recommendation for removal of the gallbladder after administering these triple 3-FTR treatment. But the encouraging thing is that the first studies showed that a combination of ribacap factor improves steatosis, reduces the need for cholic acids, improves hepatic function in children that have received 3 to 6 months after the administration of the combination. Rima factor affected the metabolism. It has interactions with other drugs, antifungal or contraceptives. It increases the hepatic enzymes. But this is transient. When these drugs are interrupted, hepatic function is restored. So it is recommended in the era of new agents to check for hepatic function every 3 months during the first year of treatment with a temporary interruption of the drug in case of significant increases of transaminases. In the most recent studies, even in polymodular cirrhosis, we have seen a reduction of transaminases and other substances without a deterioration of hepatic function, reduction of bilirubin and other indicators, improvement of steatosis. But let us curb our enthusiasm because a death was also identified in this triple combination with pre-existing cirrhosis. So we need to monitor cirrhosis, the disease, very closely. It's not the ultrasound which is the golden treatment, but elastography. All these systems, disorders from the pancreas, the liver, and dysbiosis are frequent problems in cystic fibrosis, and they lead to nutritional disorders. So the main factors is the hepatic failure in absorbing nutrients. The sound was interrupted. We have a problem with our connection. Well, thank you for what you told us so far.
We move on to our next speaker, Ms. Hatziagoru Elpida from the Cystic Fibrosis Department at Hippocrates Hospital. She's our last speaker for this panel, and she'll talk to us about what changes with innovative treatments. Good morning from me as well. Oh, we can't hear the speaker. Oh, now we can. Okay. I'd like to thank the association, in particular Anna, for having organized this whole session and event. And thank you also for the cooperation we've been having throughout the years. What's most important than everything is cooperation between doctors, between the association and the doctors, between the patients, the state, the doctors, and the association. So since you are really tired, and here, since we are running late, I'll skip some of the transparencies to share with you the most important messages. I'll start with some data from the American Registry of Cystic Fibrosis and data presented in the American conference, in the American Congress in Arizona, Phoenix. You'll know that several microbes colonizing the respiratory system are these: Staphylococcus and Pseudomonas in green and in blue. So already Ms. Diamadea has shared from the American Registry the years, etc., since 1992 to 2022, the frequency and incidence, or the prevalence rather, of the respiratory pathogens. So Pseudomonas has been reducing, Staphylococcus is increasing, and you can see as soon as we had Ivacaftor and then the triple combination, that is the Trikafta combination, how all these influenced the prevalence of these pathogens. And again, with the pandemic, the fact that these patients did not come in contact with others, there was an even further reduction of these pathogens. Since we will be talking about how the triple combination affects our strategy as to the medication, inhaled antibiotics, whether we are going to continue without physiotherapy, how we can change things, still have Pulmazan, the hypertonic solution of sodium, etc. All this is something that concerns the entire community for cystic fibrosis, and what in the States they've seen is yet another problem, in between quotes, which is a positive thing. Patients don't have big amounts of sputum, thanks to this triple combination. This means that we have fewer infections. However, we don't get enough samples for culture. So if we use pharyngeal smears, well, we know that they are not as reliable as sputum. So what we see as a reduction of the prevalence of Pseudomonas, is it 100% true, or is this due to the exam method? Now, there are here some measurements in the American registry, because they get more data as compared to the European and the Greek registries. And we see that the quantity of sputum by patients is much lower. So this affects also the way with which we isolate the microbes. So although we have a very positive element, we have reduced the prevalence of all these bad microbes, Pseudomonas and Staphylococcus. But on the other hand, it is the way we collect and sample that plays a part. This we keep in mind. So this is why in the States we have 2 studies in children under 6 and above 6 years of age, to see what's going on with infections and several parameters that pertain to the new treatment. The first findings from the PROMISE study. I don't stick to details here, but you can see how the prevalence of Pseudomonas is reduced through time. So therefore, we do have improvement in Pseudomonas concentration, but what are we going to do with the different inhaled antibiotics? These were data from the States. So respectively, we have the data from Europe, from the European Registry of Cystic Fibrosis, which is linked to the national one, the Greek one. We have collected data. We have 50,000 patients a higher number than the ones in the States. And we see what happens with respiratory infections and Pseudomonas. The countries, well, these colors show the socioeconomic level. We are ranking somewhere in the middle, in blue. And we see the prevalence of Pseudomonas in children up to 11 years of age, adolescents 12 to 17 years, and in adults. Higher rates of Pseudomonas in adults. Lower concentration in children, higher concentration in approximately 60% of adult patients. What is also impressive is that in the richer countries, we have lower concentration of Pseudomonas. So there's still a long way to go. Of course, we are not at the lower level, but we need to work on that. So what do we need to do vis-a-vis the triple combination and exacerbations? Do the data change? I'll skip all these slides. We know that in pulmonary exacerbations we have increased symptoms and reduced FEV. And it is important for us to deal effectively with exacerbations with IV antibiotics. I'll share with you what's new. So there was a partnership between the two adult centers and our own in Thessaloniki to see the first data. This was presented in the European conference, Ms. Manika, because it was her own idea. So we gathered the first patients who were on Kaftrio, 70 patients. They were the ones who were first, who had first access to Kaftrio, and they were more severe. The positive thing, well, the weight was increased significantly after Kaftrio. FEV1 significantly increased. Pseudomonas, statistically significant reduction. Respectively, reduction of the days on IV antibiotics and days in hospital. So there were many, many different benefits. These were the first patients. Now we have many more. What happened with compliance or adherence? We would tell them you will still go on pulmozine, etc., the inhaled antibiotics. But separately for each and every one of them, there was a significant reduction both in the use of inhaled antibiotics, pulmozine, and the sodium chloride one. How this will affect, well, time will tell. Because we haven't seen how the respiratory function works. So patients don't have enough sputum, those on triple combination, but we are reluctant as to whether we can decide whether they're going to go on with inhaled antibiotics. So we might see that the culture is normal. Ms. Diamandea showed a very nice transparency, showing us that the culture was negative, but the PCR was negative. So we need to be reluctant and be patient and try to adhere until more studies come up. The new studies ongoing in the States as to how we need to deal with pulmonary exacerbations. Because this is not something I'm telling you. The same concerns are for our colleagues in Europe and in the States. So 14 days good regarding the duration of IV treatment. Do we need to have aminoglycoside? Mr. Kumis said, well, no. So let us keep all that. Let's follow the guidelines. Let's be patient and stick to what the doctors tell us, even if we feel better, until we get some data. Another important part, physiotherapy. well, I don't have sputum, and therefore I don't need to undergo physiotherapy. Not only Greek patients say that, all patients say that. The tendency is to maintain physiotherapy as much as possible, but to replace it also with significant exercise, since we are doing better and our FEV1 is better. How will we respond to that? More systematic exercise, higher intensity exercise, because when I had the 30% FEV1, well, it wasn't easy. Now, with 50%, it's much better for me to exercise. I'll skip all the studies. It's a difficult time. But we see that there are many studies as to systematic exercise that can help us more. Last year's conference told us that the whole characteristics of cystic fibrosis change, and I think we can change it to the better utilizing the new drugs and treatments. Another thing, Mr. Loukidis, in his address, said that there was this adults conference from the European Society for Cystic Fibrosis and the European Lung Society. So, they held this conference for adults with cystic fibrosis in Milan. This was also a virtual conference, and we presented data from the European registries of patients on adults. So what we've seen in the past 10 years in Europe, 19 countries, from 2011 to 2021. In green, we see the number of adults. It's increasing significantly. This is why we need to place emphasis on adult centers. Gradually, this will be a disease that will need to be treated in an organized way by regarding the adult population. What do we see in this 10 years period? FEV1, only in adults. Those were not lucky enough to be on the triple combination of Kafturo. A significant increase in FEV1. Prevalence of Pseudomonas, significant reduction over 10 years. We know that patients are malnourished. And here you can see on the right the percentage of underweight patients. There is a big reduction of underweight patients. This is important. And when you get data from such a large number of data, this goes to show how advanced we are in the treatment of the disease. The complications, pneumothorax, hemoptysis, these are significantly reduced, but in red, we have diabetes mellitus due to cystic fibrosis. It is increased since we have an increase of the age limit. Then we start seeing more problems with regard to adult problems. So we start talking about obesity gradually. Now with exercise and Mediterranean diet will help us. This is going to be an adult's disease, and diabetes mellitus is going to be increased. And another thing to keep in mind, malignancy. The older the patients, the higher the incidence of malignancy. And I'll conclude here. In all these publications, we wouldn't have done it without you patients. What is important is that this is anonymous data. We can see how we can help and move on and render this a disease that will lead to the same life expectancy as with healthy people. And this is something that was published by the Ministry of Health. Basic data published for the first time from the National Registry of Patients with Cystic Fibrosis. This is our pride. This is the best registry in Greece. This is a role model for all registries. So it's important. What did we do here very quickly? We had the DPO licensing and authorization, etc. So we were able to share with you some basic data. It is available on the internet. It was published by the Ministry of Health yesterday, only yesterday. And I'd like to extend to you a big thanks for giving us your data. Many thanks to the Ministry of Health, to the DPO, Mr. Zografopoulos, Ms. Mitru, the independent registry department, and to the e-governance directorate that processes the data, checking the reliability of data. I'll share with you two figures, which we were glad to see, because we see how Greece is faring compared to Europe. Because a few years ago, there were patients saying, well, maybe I need to leave the country to have a better future. So we see 54,000 patients in 2021. You can see the figures. So FEV1, percentage, corrects the speaker, of adults and children, the same in Greece and in Europe. FEV1, well, you can't read. 100% better in children. The BMI for children and the BMI for adults. Exact same data. We need to do some work on Pseudomonas. In children, we have same rates as in Europe. In adults, though, we have higher rates as compared to Europe. In the past, we used to have higher rates in Pseudomonas in children as well. So we don't need to discontinue the inhaled drugs. So a big thanks to all. Thank you. Thank you.
Ευχαριστούμε κυρία Χατζιαγόρου, ευχαριστούμε όλοι.
Thank you. Thank you all. Thanks to all doctors. I don't know if we have time for questions. We will not have a break. We will go directly to the transplant panel. And then during lunchtime, we will talk. I have hosts of questions, but I don't think there is enough time. Mrs. Fotoulaki. Could I summarize my basic points because the connection was interrupted? You cannot see me now. It doesn't matter. What is important as to the administration of new treatments for digestive disorders, if we administer to children early on CFTR modulators, it seems that the pancreatic and the hepatic function can be preserved, which is very important. And something else I wanted to say, the risk of obesity is an existing risk. Already in 1999, 12% of children were obese or overweight, whereas in 2019 that was 32%. So 1/3 of children are overweight or obese. Already the alarm should be sounded. So at the same time with malnutrition, we have to deal with obesity. And this is purely through the administration with individualized diet, each child according to their need, We don't need hypercalorific solutions, and the Mediterranean diet should be adopted. These are messages that I'd like to send to you, as I did not have enough time earlier. Thank you very much, Mrs. Fotoulaki.